Hi, everyone. It is my pleasure to discuss the Geriatrics 5Ms framework in this workshop today, from concept to practice. I have no financial disclosures. These are the objectives for this 45-minute session. The workshop's overall goal is to provide you with evidence-based point-of-care tools and resources aligned with the 5Ms framework that could be easily integrated into the clinical care of older patients. So, as you all might already know from being part of this course, we are caring for an increasingly aging demographic. As you can see on this graph, in 2020, about 16.9% of the American population was 65 years or older, a figure that is expected to reach 22% by 2050. This is a significant increase from 1950, where only 8% of the population was 65 or older. So these changes in demographic brings to clinicians like us challenges that include managing multiple medical problems and multiple medications, assessing function and helping patients maintain their independence, and all with our time limitations that we have in our workday. My hope is that this workshop and understanding the 5Ms will address some of these challenges and help us take better care of our older patients. The Geriatrics 5Ms, or the Geri 5Ms, is a simplified communication framework to describe the core competencies in geriatrics and has come to represent a framework for exceptional geriatric care. As you can see here, it includes mind, mobility, medications, multi-complexity, and what matters most. Clinically, it has become more relevant as more and more health systems create the models for age-friendly care. And even as an educator, now there are competencies for medical students and advanced trainees around the 5Ms framework that can assist in the creation of curriculum in this era of competency-based education. So the Geriatric 5Ms is applicable to all sites of care for older adults. And here is just a quick snapshot of what the 5Ms entails with some of the components within each domain. I added a hearing impairment within mind because I think it's somewhat relevant, and we'll go over each of these in a little bit more detail. I want to acknowledge that you will hear individually about each of these 5Ms at other workshops and plenaries. So you might see me going through the slides a little bit quickly, but they're all available for you for review in your own time. Let's start with a patient, Mr. Bentley. He's an 82-year-old male with a past medical history significant for hypertension, diabetes, benign prostatic hypertrophy, and osteoarthritis of hips, and a history of myocardial infarction 10 years ago, who presents for a pre-operative evaluation. So there's a video to start us with.
Good morning, Mr. and Mrs. Bentley. I'm Dr. Rodriguez.
Good morning, Dr. Rodriguez. This is my husband, Dave. Please forgive him. He's forgotten to tune up his hearing aid.
Hello. Hello, sir. Well, let's get started. Can you tell me your medical problem, sir?
Well, he has diabetes, hypertension, and arthritis.
And do you take any medications?
Well, I brought a list of his medications. Hydrochlorothiazide, glyburide, vitamins, baby aspirin, something for pain, and a sleep medicine.
Okay. And sir, are you a smoker, or do you drink any alcohol?
Well, I used to smoke, and I have a whiskey now and again.
How is your memory?
It's fine.
I'd like to do a test of your memory, if you don't mind.
Sure.
Great. What is your name?
David Bentley.
Where are you right now?
Your office?
All right, there are so many things we can discuss from that introduction video of Mr. Bentley. I think one of the things that it demonstrates is the importance of communicating with family members and caregivers in order to obtain collateral information, especially in those with concerns about cognitive impairment. So we won't get into the details of other kind of discussion points from that video, but it'll bring us to our first of the 5Ms, which is the mind. And we'll start with the discussion about one of the main things we talk about, which is dementia. It's fairly rare in adults younger than 60. It's about 7%. However, after age 60, it is relatively rare in adults younger than 60, but after 60, it's about 7%. Really gets to about 30% in those 85 and older. And the two most common causes of dementia, or the syndromes associated with dementia, are Alzheimer's and vascular dementia. There are many screening tools that we typically use in the evaluation or screening for cognitive impairment, and the choice often depends on the patient's education, literacy level, primary language, site of care, and how much time the clinician has in order to elicit the screening. So I'll demonstrate just a couple different tools here. The mini-cog is one of my most commonly used tools in the office. I tend to do that at annual wellness visits, as well as post-hospital discharge visits, as a quick way to glean if there is something to be concerned about. It is a combination of a clock drawing task and an uncued recall of 3 unrelated words. In this case, we've used penny, dog, and orange. It is considered normal. The clock drawing test is considered normal if all the numbers are present in the correct sequence and the hands display the correct time in a readable way. As you can see, it's fairly easy and quick, takes between 1 to 3 minutes. It's not greatly affected by education or language proficiency, and it's quite sensitive as a test for cognitive impairment. It is a mini-cog is a very feasible way of gauging a patient's cognitive status and can be used, like I said, preoperatively, postoperatively, and a variety of other things. Something I'd like to point out is that positive mini-cog, which means an abnormal mini-cog, is associated with functional disability, surgical complications, postoperative mortality, as well as increased hospital length of stay and postoperative nursing home placement. So something that we should consider doing, especially those among us who are working in the hospital setting and have so many things to take care of, but not enough time to do that. A more kind of comprehensive exam that you may have heard of is the mini mental state exam, MMSE. It's quite widely used, however, patent protected. Its a maximum score on the MMSE is 30 points. And using a cutoff of 24 points, it has a pretty good sensitivity of 87% and a specificity of 82% in a hospital-based sample. However, it's not sensitive for mild dementia, and it can be influenced by age and education, as well as by language, motor, and visual impairments. As we do it, we must look for patterns of missed questions, which can be as important as the overall score. For example, if a patient misses all of the recall questions or all of the language questions, then that maybe hints at a significant decline. The use of higher cutoff scores on the mini mental state exam improves sensitivity but lowers specificity. And some research studies often use a more sensitive cutoff of 26 to 27. The MMSE also has utility in assessing decision-making capacity. However, it's not a substitute for a formal assessment of capacity. And so while low scores like less than 16 points out of 30 in patients with dementia due to Alzheimer's disease are highly correlated with impaired capacity, higher scores may or may not correlate with full capacity to make decisions. This is an interesting slide, shows the norms for MMSE score as it varies based on age and educational status. So let's say you have an 80-year-old patient who has a mini mental score of 22. It would be important to know what their educational level is. If they've had less than 4 years of education, it might actually, the score of 22 might actually be not so concerning for dementia in this population. In general, the scores, I think about the 20s as mild dementia, the 10 to 20 as moderate dementia, and 0 to 9 as severe dementia. A third test that, again, I use fairly often is the Montreal Cognitive Assessment, or the MoCA, which has been validated in a setting of mild cognitive impairment in multiple languages as well. And there have been now versions for those with disabilities and limitations, like those with visual impairment, hearing impairment. And around the time of the COVID pandemic, they even came out with a telehealth version. There's a phone version as well. So it's worth taking a look at this website, www.mocatest.org, and getting a little training and getting certified before using the MoCA. But it's a fantastic test, has the ability to distinguish, like I said, the mild cognitive impairment, which can be a very good place to start screening and diagnosing now with newer therapies for MCI and early dementia. So the MoCA, this is the kind of what the MoCA looks like. In recent years, we have become more familiar with this MoCA in kind of the mainstream media. And the total score is again 30. We take 26 or more as a normal score. There is a space to add 1 point at the end for someone who has less than 12 years of education. Someone who didn't complete high school might benefit from that extra point in terms of classifying them with dementia. So coming back to our patient, this is Mr. Bentley's score. He got a 20. If you look all the way at the bottom, he did get an extra point for less than 12 years. So his overall score is 21, puts him in kind of the mild dementia category. All right. Here's another useful tool that was recently published. When you are going from someone's prior MMSE score to a current MoCA score, or vice versa, this particular grid provides you kind of comparable scores when going from one cognitive test to the other. So you can also kind of bookmark this particular table as you are seeing patients. So which one to use? We've already highlighted a couple of different screening tools. There are a couple more, like the 88 dementia screening interview, as well as the St. Louis University mental status exam. They all have pretty good sensitivity and specificity. They take varying amounts of time to administer. So really it depends on your comfort, practice, and what your office's stock in terms of the questionnaire. I do want to also introduce the functional assessment stage. The FAST scale is often useful once the patient has been diagnosed with dementia. Not a screening tool, but it can be used to stage the progression. It includes components of their functional status, i.e. ADLs and IADLs, to provide an estimate of their prognosis. I will caution you that the average duration or life expectancy on the extreme right is a very general ballpark number. It is not an absolute number. It's very variable. However, you can see that when someone's at stage 7, which goes 7A through 7F, is when they are unable to communicate verbally. So their speech is limited to less than half a dozen intelligible words. And they have progressive loss of ability to walk, to sit, to smile, to even hold their head up. And that is when we can often make a recommendation for evaluation for hospice eligibility, which is typically for someone who has 6 months or less to live. Although there are some additional criteria that patient has to fulfill before they can be approved for hospice care. So this is something that can be utilized for patients who already have dementia. This slide I wanted to bring just to highlight that there have been studies to show what are the predictors of shorter survival in dementia. And you can see that those with pre-existing gait impairment or history of falls or urinary or fecal incontinence, as well as those with a host of comorbidities like heart disease and heart failure and diabetes, often have a shorter survival when they have dementia. And this just goes to highlight that there's intersection of the various 5 M's. So you have the mind, but now there is an intersection between mind and mobility and multi-complexity. Moving on to another M, another syndrome within the mind M is depression. And overall, men and women over the age of 65 appear to have lower rates of severe depression compared to the rest of the population, right? There are many reasons for that. But there are three forms of major depression that are relatively common in later life. And these are dementia, depression associated with dementia, which is where depression symptoms are similar to those of dementia. There's also depression related to physical illness, someone suffering with chronic illness, maybe taking several medications. Often the side effects of medications can contribute to depression, and so on. And then there's depression associated with bereavement. As we get older, we are more likely to face the loss of family and friends, and that can often, lead to grief, and then, complicated grief, and so on. And that can also manifest in the form of depressive symptoms. There are some screens that are often used in offices. You may already be aware of PHQ-2 and a PHQ-9. Usually starts with questions like, over the past 2 weeks, have you been bothered by little interest or pleasure in doing things and feeling down, depressed, or hopeless? And then usually in our offices, the medical assistants are asking these questions at initial triage. And then if it screens positive, they are provided a questionnaire, or the clinician ends up asking some of the more detailed questions on the PHQ-9. Hearing loss is a common chronic condition in older adults. About a third of older than 65, and half of those older than 85 have some sort of hearing problem. And so really something that we should be screening in our annual wellness visits for presbyacusis, which is the age-related hearing loss. And it can lead to depression, withdrawal, loss of self-esteem, and just overall unhappiness with kind of life and motivation, lack of motivation. And so these are some tips for addressing patients who have hearing impairment, depending on kind of your office workflow. So your patient, Mr. Bentley, is admitted for elective hip arthroplasty surgery, and a geriatrics consult is called to evaluate postoperative status and to assist with discharge planning. So we've moved ahead by several weeks now, and here's a video that I'd like for you to pay attention and then maybe note any thoughts about his mental status.
Good morning, Mr. and Mrs. Bentley. How you doing today?
Good morning, doctor. I don't think he's doing very well this morning. He just wants to sleep.
Well, the surgery went fine. What do you think's going on?
Well, last night he just kept going on and on about fish in a tank. We don't even have a fish tank.
Mr. Bentley, good morning.
Well, I don't think he can hear you. He doesn't have his hearing aid.
Mr. Bentley, good morning. Can you open your eyes for me? Good morning. Can you tell me where you are?
Angelfish. Seahorses. Yeah.
So the question here for all of you are, what are some features of delirium that you could see in this video? And there are several of those. Obviously, video is made to emphasize someone's delirium, but you can easily spot kind of the disorganized thinking. Patient is saying angelfish and seahorses. There is altered sleep-wake cycle with excessive sleepiness during the day. There's altered level of consciousness. There's drowsiness and inattention to the questions that the provider is asking. So brings us to kind of a really important tool called the confusion assessment method, which is certainly going to be covered in another workshop, which relies on 4 key criteria. First one is an acute change in mental status and fluctuating course. Second one is inattention. And you need both of these for sure. Plus, you need a third or the fourth criteria, which is disorganized thinking or an altered level of consciousness. CAM is a simple and highly useful bedside tool to help diagnose delirium with a really high sensitivity of 94% and specificity of 89% under most circumstances. And hopefully this helps with diagnosing delirium, which is still pretty under-recognized in our hospitalized older adults. It does benefit from having a high index of suspicion, knowing the predisposing and precipitating factors for delirium, and repeated examination. Going back again and seeing your patient, a different time of the day certainly helps greatly to distinguish normal from abnormal. So here I will just quickly highlight that this is a simplified version of CAM, or called the 3D CAM. It's a 3-minute diagnostic CAM. 3D CAM highlights the 4 features, and in red you can see that you can attest any of these features either through self-report or by looking for signs or symptoms of each of these components. And again, this does not require extensive training, probably just a lot of practice. I really love this schematic that was put forth by Sharon Inouye to explain the incidence of delirium in the hospital. That is an interplay of having several predisposing and precipitating factors that increase or decrease someone's risk of or chance of delirium. So if you have high vulnerability, which is a high level of predisposing factors, you don't need a whole lot of precipitating factors. You can just have a small insult in the hospital, a minor infection. Someone who is more robust and less frail and fit with few predisposing factors may require a kind of a major insult in the hospitalization process to have delirium. So just being aware of this interplay, and that way seeing your patients as different from each other, and acknowledging that delirium is often multifactorial. Here is a list of what we call delirium risk increasing drugs. Very expansive, that can cause, they're all deliriogenic, certainly to be used with caution in patients with dementia. And kind of this takes us to kind of our next component of the 5 M's, which is the medications. So as you already probably know, there are pharmacokinetic and pharmacodynamic changes with aging. So first, the pharmacokinetics has to do with what the body does to the drug, the 4 processes of absorption, distribution, metabolism, and excretion. And those are quite different in older people, right? You can think about hepatic metabolism and renal excretion and the blood-brain barrier permeability. All of that is different. And so that's why we often, tend to say, start low and go slow when prescribing for older adults. The pharmacodynamics, which is what the drug does to the body, is also very important, which is how the drug manifests its action. So you can see here, for example, on the right side, for the same drug concentration, an older adult can have a more heightened response to the same drug concentration. And so really important to have as low of a dose to start with, and keep monitoring patients in terms of how they react and respond to that particular dose. Here's just again a table that demonstrates that an average glomerular filtration rate, or creatinine clearance, changes as people grow old, even without chronic kidney disease. So, even from pure aging, from physiologic changes of aging, your GFR can reduce, and therefore we need to be aware of these metrics as we dose medications and provide management strategies. As a geriatrician, I find really interesting that many presentations in older adults in emergency rooms and office visits can be manifestations of an adverse drug event, ADE, and can mimic a geriatric syndrome. Here are some examples that are worth reviewing in your own time. I'll just leave you with an example of someone, let's say, who presents with new confusion or memory problems. It is critical to do a thorough medication review to rule out inappropriate use or adverse effects related to a medication, let's say with anticholinergic properties or neuropsychiatric medications like benzodiazepine. Medication reconciliation through brown bag review is still very efficacious. It can be time consuming, but it can be really satisfying for both the provider and the patient and family members. And it involves several steps. But to start, it requires the patient to bring all their bottles with them from home, both prescription as well as non-prescription and over-the-counter medications. Going back to Mr. Bentley, at his post-discharge visit, you review his medication list, and he's concerned that he takes too many medications and has difficulty keeping track of the reason why he takes those medications. And as you perform the medrec, you ask what time he takes each medication and what he takes each medication for. He says, I just take what the bottles say. So you recognize that there is polypharmacy and that some medications can be modified. So what are some tools that we can utilize? Hopefully you've all heard of the 2023 AGS Beers criteria, which is the most recently updated Beers criteria. It comes in a pocket card or pocket book format from American Geriatric Society, and can be used in all settings of care. So, from nursing homes where it was originally designed to help, all the way into the hospital care as well as outpatient and home-based care. It lists medications that are more risky than beneficial, and that because of which it makes it more ineffective, or it poses more risks, or if there are safer alternatives available. As an example, I can show you the first one is about antihistamines. As you can see here, it provides you a quality of evidence. In this case, it's moderate quality of evidence and a strength of recommendation based on the best literature evidence, and provides some detailed kind of description of whom to avoid and why and so on. There's also other kind of tools like the anticholinergic burden calculator. There are many such available. One of them is this acbcalc.com, where you can plug in the medications as we did for our patient and identify that this patient, or Mr. Bentley, has scored 3+ or has scored 6, which is certainly at higher risk for confusion, falls, and death. It's time for a little comic break. So like this provider is just giving out another prescription with their eyes closed. It's a perfect time to discuss the prescribing cascade, which is when an adverse drug event is misdiagnosed as a new medical condition and treated with an unnecessary medication. And this can put the patient at risk of developing additional side effects or what we call adverse drug events related to the new and potentially unnecessary treatment. And the cascade can keep going on, right? So someone has to identify that the presentation is a side effect or a medication effect, and then stop the first medication as opposed to adding a second and third medication. A good example of this, amlodipine, which is a calcium channel blocker often given for hypertension, has a very well-known side effect of pedal edema, which occurs in about 6 to 10% of people who take amlodipine. Oftentimes, providers might be prescribing furosemide or another diuretic to get rid of the pedal edema without recognizing that amlodipine may have contributed to the pedal edema. And then that's another medication, often with its own side effects of running to the bathroom and all that, but then can also cause hypokalemia. And now at the next office visit, this patient has a low potassium, so they're asked to go ahead and start a potassium supplement. So there you go. We have 3 medications where we could have just chosen a different antihypertensive and avoided the cascade. There are many other examples of this. Another one that comes to mind with our patients is the chronic use of antipsychotics. Let's say for someone with dementia, can over months to years of use can lead to Parkinsonian or dystonia type symptoms, and then kind of lead to prescription of anti-Parkinsonian medications. NSAIDs for pain can lead to high blood pressure, leading to starting of antihypertensive therapy and so on. So deprescribing is very important, and we can reduce polypharmacy with a planned and supervised process of dose reduction and stopping medications that may be causing harm or not providing any benefit. Here is kind of one protocol that was published in JAMA in 2015. Again, that starts with reconciling all medications considering risks and benefits, and then slowly kind of prioritizing which medications to reduce or stop, and then having some sort of a monitoring plan, follow up, right? And here's some ways in which we can do each of these steps. I think much of this we've already talked about briefly. It is really important to have patient buy-in when you do any sort of deprescribing. Patients often get attached either emotionally or physiologically to their medications and may not love the idea of getting rid of a medication, right? So it's important to discuss this plan of a slow taper with constant follow-up and monitoring with your patients before. Certainly cost is an issue, so saving money can be also a kind of an added advantage or benefit to patients. Here's one example of what is available on deprescribing.org to kind of go taper someone's proton pump inhibitor that they may have been taking for many years without any sort of specific indication like peptic ulcer or Barrett's esophagus or anything like that. And it's a fairly commonly misused medication in our patients. So, just a quick tidbit on kind of the less is more, particularly with antibiotics. As we know, antibiotics are super helpful for our older patients or any patients in reducing infection, but they are also associated with a lot of misuse and side effects like diarrhea, but also increasing the risk of antibiotic resistance. So there's a lot of data now, and there's also an ACP guideline that talks about a shorter course of antibiotics. So kind of be mindful of how short can an antibiotic course be, unless you think that it's a complicated infection. So with Mr. Bentley, this is his original list, and we said he was concerned about a longish list. So we used some of the knowledge of the Beers and the anticholinergic calculator, and we identified that alprazolam, glyburide, diphenhydramine, and omeprazole as Beers list medications to avoid and reduce. And then we also looked at diphenhydramine in particular as anticholinergic burden, along with the furosemide and alprazolam and metformin and senna, which may represent the end result of a prescribing cascade. So with that, we made some recommendations for our patient, which is to stop the Benadryl or the diphenhydramine, to consider melatonin for sleep, for insomnia, to taper the alprazolam in this format, to taper the omeprazole over time and use over-the-counter medication as needed, stop taking the glyburide and check the blood glucose and then come back, and then consider prune juice and increasing fiber, and then using acetaminophen every 6 hours for pain, and then follow-up is always good. So in follow-up, he said that he has successfully stopped many of these medications. His blood sugars are somewhat in the manageable range. He continues the alprazolam twice daily, without which he's unable to relax and sleep. And unfortunately, a month later, his wife reports that he fell in the bathroom 2 days ago and hurt his right shoulder. At that point, you said you asked him to come for an urgent visit to evaluate a fall. So here we move on to our next M of mobility. There's a whole plenary and workshop on falls evaluation, so I'll breeze through these slides that talks about the extreme prevalence of falls in older adults. Again, as a practicing geriatrician, I am just intrigued by how many people are falling, especially when you ask about non-injurious falls or near falls. Oftentimes, they can predict and help you identify who's at risk for future falls with injuries. And really, the key statistic here is a third of older people are falling every year. And once you fall, you're at particularly higher risk for falling again. Here's some more data on, how the burden of falls on our health system with the ED visits and hospitalizations. I really want to point out the long lie, which is when patients fall down and are unable to get up, which is a fairly common occurrence in older people. It can lead to real medical problems, so to speak, like dehydration, rhabdomyolysis, pressure sores, pneumonia. And cognitive impairment is a predictor of long life. So again, you see kind of the interplay of the five, the M's, the mind and the mobility are kind of closely linked. So we really have to be cautious in patients who have problems with two of those M's. This is to highlight that it's a vicious cycle that follows falls. Usually people who fall continue to feel afraid of falling and therefore curtail their social activities in a syndrome that is called a post-fall anxiety syndrome. And that leads to restriction of activity, reduced muscle mass and fitness and functional decline. And then, they become more frail and predispose themselves to further fall. So it's an unfortunate vicious cycle. When I'm teaching students and advanced trainees, I find that the history of falls, the multifactorial nature of falls can be challenging to elicit from patients. So here's a schematic we created to help you identify a host of intrinsic kind of features and extrinsic features as you do your history taking with patients with falls. Certainly asking about a history of prior falls and their history of assistance with ADLs and IADLs are important. Similarly, these are the things we need to examine for patients who have fallen. For the purposes of this particular workshop, we'll focus on kind of the gait and balance assessment, which focuses on motor, balance, and gait and coordination. For the strength assessment, I often lean on the 30-second chair stand, which is asking a patient to sit in a chair without armrests, asking them to put their arms on their shoulders or on their other hand, other arm, and then stand and sit as fast as they can for 30 seconds. Here's kind of the grid for what's normal. And so for patients that I am seeing, typically I use the rule of 10. So patients in their 80s, if they can do about 10 chair stands in 30 seconds, that is reasonable. Anything less than that is abnormal. For the functional balance assessment, I use the four-stage balance test. I usually use only the 3 stages of parallel, semi-tandem, and tandem. So in this case, you're standing with your feet side by side. This is the parallel stance. Someone who is wobbly at this stage, that indicates significant balance issues. The second step is to place the instep of one foot so it is touching the big toe of the other foot. So somewhat semi-tandem. And the third is to place one foot directly in front of the other with the heel touching the toe, and asking them to maintain each of these 3 stances for 10 seconds, right? So inability to do that indicates risk of falling. And the third kind of more comprehensive and well-validated test is called the timed up and go. Again, this is something you will review in a different workshop. I will briefly show you some videos that go over what instruction you want to provide to the patient and what to look out for.
Mrs. Norton, I'd like you to rise from that chair without using the use of your hands or arms, walk across the floor, and return to the chair.
So that seems fairly normal. Now see an abnormal one.
Mrs. Norton, I'd like you to rise from your chair, if possible, without the use of your hands and arms. I'd like you to walk across the floor and return to your chair. I'll be timing you during this walk.
You can see she has some difficulty getting up from the chair without the use of her arms. Probably some quad muscle strength deficit there, or some pain issues. She also has a poor arm swing as she's walking, and I can note some unequal steppage. The step length is different. So certainly some abnormalities there. Certainly less than 13 to 15 seconds to do the whole test is considered abnormal in research studies. I will just kind of briefly share that exercise interventions have been proven to help. There's a Cochrane review analysis here. And any exercise is good but certainly exercises that focus on balance and functional activities, and certainly those that focus on balance, functional with resistance activities are highly efficacious. So really suggest any of these exercises. Tai Chi is also pretty good in fewer studies. Walking alone is not known to be helpful. So the common response from patients is that, oh yeah, I walk every day, which is fantastic to do for the heart, for the brain, not necessarily to improve muscle and balance and strengthen ankles and so on. So what is most likely to be effective? A combination of exercises, group-based exercise, multiple exercise components, certainly a higher dose of exercise, more minutes per day, and long-term exercise interventions if people can keep doing it for months to years. So Mr. Bentley demonstrated some motor and balance benefits. The timed up and go was 15 seconds with some instability at the start and when turning around. His standing blood pressure was 108/70, which was quite lower than the sitting blood pressure of 135/85. So at this point, we thought this could be orthostasis. We recommended he drink 5 to 6 glasses of water. Certainly we wanted him to taper the alprazolam because of its risk of falling from that, and then starting physical therapy and a home exercise plan. And he hadn't had a vision check in a while, so certainly given his history of hypertension and diabetes, we wanted him to see the eye doctor. And you schedule an annual wellness visit in a month. Here's a home safety checklist. Many checklists available like this. You can quickly hand it over to the patient, and they can, or to often an occupational therapist or a home safety evaluation involves some sort of a checklist like this. I will skip the discussion about the cane and the walkers because it will be covered under a different workshop. You have these slides available for you in case you need to come back and identify which assistive device is best for specific patients. When Mr. Bentley returns for his wellness visit, you see that he's up to date with his vaccines. His wife talks about him never having received a colonoscopy. Thankfully, he doesn't have a personal or a family history of colon or other cancer. He's resistant to get screened, but now says, I will do what you think is right. So brings us to the multi-complexity component of the 5Ms, where we talk about how do we care for older patients who have multiple diseases, medications, and the clinical guidelines and the data that we have, although it's improving, is not complete. We don't really know how to treat someone who's above 85 or even above 90 or 95. There are also other psychosocial factors, caregiver issues, and certainly, the patient preferences are so variable as you grow older that really have to listen to your patients and what they want. The American Geriatric Society has kind of a framework for how you can deal with multi-complexity. It is challenging despite using some of these frameworks. There is a Choosing Wisely campaign from American Geriatric Society and ACP. And, it talks about not recommending screening for cancers without considering life expectancy and the risks of testing, overdiagnosis, and overtreatment. And so just for an example, for our Mr. Bentley, colorectal cancer screening is a high-grade recommendation from USPSTF, A-level recommendation for those 50 to 75, either with stool-based tests or direct visualization tests. However, there is a recommendation to not screen, which is a D recommendation for those above 85. It's a B recommendation, which is, considered in individual patients from 45 to 49, and a C level recommendation from 76 to 85. So for Mr. Bentley, it is a C level recommendation, which is really based on patient preferences and his life expectancy. Here's a table that talks about previously unscreened individuals like Mr. Bentley, who are already past the age of screening of 75. It may be cost effective to screen them up to, some 80s, somewhere in the 80s, either with sigmoidoscopy, colonoscopy, or with stool-based tests. There is eprognosis.org, or eprognosis.ucsf.edu that has very helpful screening tools to help you pick what kind of what might be the prognosis of your patient. So they'll ask you for the patient's details, and then for this particular patient, you can see that screening would generally not be recommended. Again, we don't want to just go by what ePrognosis says. We really want to use our knowledge of the patient's comorbid conditions, and then make that assessment. Here's is kind of a shared decision-making tool, which talks about how many patients like Mr. Bentley would benefit. In this case, after 10 years of 1,000 people like Mr. B who got tested for colorectal cancer, one patient would avoid death from colorectal cancer, right? And after 10 years, 900 will die whether or not they got tested for colorectal cancer, right? So this kind of brings it, makes it real in terms of what is the real benefit that we are getting from screening for colorectal cancers. So based on your evaluation and his preferences and his overall prognosis, you recommend no further cancer screening, and you request your social worker to speak with the wife about caregiver issues, home care needs, and support systems. And you take this opportunity to discuss his goals and choice for healthcare proxy. So brings us to the last couple minutes of this session, which is about matters most. I use a couple different tools, one of which is Prepare. Again, the website to go for this is prepareforyourcare.org. Really helpful website, walks patients and caregivers through 5 steps in figuring out what matters for them, who matters for them, what are some of their wishes, and then help you provide with the healthcare proxies. Here's another kind of relatively new movement spearheaded by Dr. Mary Tenetti called Patient Priorities Care that helps patients and clinicians focus all decision-making in healthcare on what matters most, which is the patient's health priorities. So what this does is it provides you some sort of tools to identify what are some things that makes patients' care burdensome for them, and what are some, when faced with trade-offs, what kind of goals do they have for themselves? What do they want to achieve from their healthcare? What do they want to be able to do in their daily lives? And then what are their care preferences in terms of what can they do to achieve those goals? So it removes kind of the diseases and medications a little bit out of the way and puts it on the provider's side to kind of help lay out based on the patient's goals and care preferences. So I highly recommend you take a look at some of the work that they have done in this. So, Mr. Bentley assigns his wife as his healthcare proxy and his son as an alternate agent. His goals, as you elicit, is to have as little pain in his joints as possible. Hopefully the knee surgery that he had done helps, and the physical therapy that follows. Getting together with his son and grandchildren weekly to watch sports is important to him, and not being a burden on his wife is always on his mind. And so I just want to close this discussion with the fact that Geri 5Ms can be really helpful framework to utilize in clinical practice, particularly when you have a very complex patient in a very limited time. You really want to prioritize the complex issues. You don't want to get into the minutia. You want to kind of solve some big problems, high priority problems. It can be very helpful. It can be helpful to write your geriatric consult notes and communicating with other specialties who are often focused on individual things, right? The cardiologist is focused on the heart. The endocrinologist is focused on the diabetes and osteoporosis. We can be focused on the 5Ms. And I think that's really a helpful framework for that. And then really an important role for interdisciplinary team members and evidence-based resources to be involved in the care of older adults. So again, thinking for ourselves as providers, but also as we teach our students and trainees, who else can we lean on? Taking care of older patients is not an individual sport. It is a team sport. So really, who can we involve that can partner with us to take better care of our patients? And here's a list of all kinds of tools and providers and specialists that can help with that kind of stuff. With that, I'll close, and I really want to acknowledge Jill Gregory, who created some of the really wonderful schematics and figures, including this 5Ms schematic for us for this presentation. Thank you.